for today. Sounds like we're ready to go and getting it recorded. So we have Dr. Rachel Malta. Um, she is a clinical pharmacist that completed her Doctor of Pharmacy degree at the University of Florida, St. Petersburg campus, and completed her postgraduate pharmacy practice residency at Tampa General Hospital here in Tampa, Florida. And she's really worked as a specialist of transitions of care and geriatrics, and is currently working on the hospital at home team within Tampa General that really focuses on providing in-home, inpatient level care for our geriatric patients in the area. So we're excited to have you, Dr. Malta. Thank you for being here, and I will turn it over to you for Dementia CE.
Thank you so much for the introduction. Just want to make sure my mic is working. Can you hear me okay?
We hear you.
Thank you. Well, thank you guys so much for having me. It is a pleasure to speak to you today about this topic. It's very near and dear to my heart, so I'm always happy to spread information and awareness. I am going to turn my camera off because my computer gets a little huffy when it has too much to do. I'm not that much different, so hopefully my audio is still on, and we'll just dive right in. So our learning objectives for today are to identify the most common types of dementia. We'll go over some non-pharmacologic and pharmacologic interventions, and we'll go over some pearls for management of dementia in the long-term care setting. So we're going to start off with a polling question. So Lisa, if you would be able to open that for us. I wanted to ask, out of my own curiosity in researching this topic, I found dementia to be a very common disease state, more so than I was aware of, really. So I was just curious of the people we have here, how many of us know someone personally that's been diagnosed with dementia? I know, likely we work with these types of patients, but if it's touched your family or personal life, I would just be curious. I do have an interesting statistic that I found. I was curious if we correlate well with the statistic. Yeah, so we do. I don't know if you all can see the results, but 63% said yes. That's not shocking, considering 1/3 of all people aged 85 or older will have some form of dementia. So I think it's a very important topic and one that, potentially touches a lot of our lives. The dementia is an acquired disorder that is characterized by a decline in cognition involving one or more cognitive domains, learning, memory, language, executive function, complex attention, perceptual motor skills, and social cognition. In the next 30 years, people living with dementia is expected to rise from 47 million to 131 million. So dementia is an umbrella term that can refer to any of these subtypes that we commonly see. So I am going to go over some of these types, but we are going to start with Alzheimer's disease, since that is the most common one that we see, and a lot of where our data comes from when we look at dementia. So Alzheimer's disease is thought to be due to an accumulation of two proteins within the brain. First, beta amyloid proteins accumulate outside the neurons, and second, we have twisted strands of the protein tau that accumulate inside of the neurons. So it's thought that these plaques cause neuronal death and result in inflammation and atrophy of the brain tissue. So it's expected to affect 13 million people by 2050. So putting that into context, there are 65 million Americans living with dementia right now, so expected to double in the next 30 years. So we can see the rate of developing or being diagnosed with Alzheimer's every 3 seconds globally, or 60 seconds in America. So again, quite a common disease state for us, and we will continue to see it worsen in our lifetime. So looking at mortality, in the numbers that we have from 1999 to 2014, we saw a 54% increase in mortality. We have further breakdown of exactly where those patients passed away and where they're being cared for currently. So it's a common issue for us working in nursing homes, but the data from 1999 to 2014 did have an interesting trend. Less people passed away in a hospital, and actually more people died at home or in a home setting with caregivers. So coupled with the significant increase in Alzheimer's death overall, this likely has added a significant burden on family and other unpaid caregivers. So I would be interested to see in the next few years of data that are going to be analyzed, we may see a shift back towards a nursing home setting due to caregiver burnout. So September is Alzheimer's Awareness Month. So that is why I chose this month for this talk. I really should have chose next Wednesday because that is Alzheimer's Awareness Day. But if you follow the link on the slide, there are a few things that you may find interesting. There are some opportunities to get involved with research. So really anyone is able to participate in these studies regarding prevention. So this is a global problem. It's going to worsen. So whatever we can do to further research efforts and spread awareness will help. You can also read about the CDC's Healthy Brain Initiative with some strategies for prevention. So moving on to some of the other forms of dementia, Lewy body dementia and Parkinson's disease dementia are dementia syndromes that overlap in many clinical features, genetics, neuropathology, and management. So they're kind of considered subtypes of the spectrum of Lewy body diseases. So these are characterized by the protein alpha synuclein. So clumps of this protein make up the Lewy bodies. So when these clumps start out in the cortex, the patient most likely will lead to a diagnosis with Lewy body dementia. When these clumps start in the substantia nigra, they are thought to cause degeneration of the nerve cells that produce dopamine. So these patients are more likely to develop Parkinson's disease. And then when or if these Lewy bodies spread to the cortex, that's when the Parkinson's disease dementia may become apparent. So these are distinct diagnoses, but for this presentation, I have lumped them together because much of the data is very similar between the two. So for vascular dementia, this is caused when blood vessels in the brain are damaged and or brain tissue is injured from not receiving enough blood, oxygen, or nutrients. People with changes who develop dementia symptoms are said to have vascular dementia. However, it is more common as a mixed pathology, with most people living with dementia showing the brain changes of cerebrovascular disease and Alzheimer's disease. So vascular dementia is considered a non-neurodegenerative dementia, meaning it may be reversible or progression slowed or halted if the underlying cause is treated. But again, since most people have some element of Alzheimer's as well, it is common to see a progressive decline. So frontotemporal dementia is caused when nerve cells in the front and temporal lobes of the brain die and the lobes shrink. So upper layers of the cortex may soften and abnormal amounts of the protein tau and or TDP43, which is transactive response DNA binding protein 43, are present. So this is a more rare form. Oh, I skipped one, yeah. So USPSTF has stated there's insufficient evidence to recommend for or against routine screening for dementia in older adults, and other organizations have also agreed. But thorough workup is recommended if cognitive difficulty is observed during a patient encounter or a patient or family expresses concerns. So how do we grade or assess cognitive function in dementia? So there are a few scales here that we can use, and some of the data that we'll look at do mention these. And these tools measure cognition, global assessment, function, and less commonly behavior. You can see the cutoff for what we consider a clinical significant change in each of them. It's really beyond the scope of me talking to you today to get into diagnosis for each of the various types and subtypes. That could be a whole hour just in and of itself. So I just wanted to present this so you have it. But diving into the mini mental state exam a little closer, and how it's used to grade the severity of dementia, with mild being difficulty remembering recent events, maybe some issues driving, wondering if this is why driving in Florida is so exciting, to severe with patients being unable to care for themselves. So these scores are not absolute and can vary a little bit day by day, depending on if someone's having a good day or a bad day. But overall, the trend is toward a progressive worsening. So I did want to touch on mild cognitive impairment, or MCI. So this, again, could be a whole hour talk in and of itself, but I did want to mention it because it can be thought of as being like a stepping stone to being diagnosed with dementia. And it is thought of as being slightly worse than the subtle changes in cognition that occur with normal aging. But we do have a study that found only 15% of patients that were diagnosed with MCI actually progressed to dementia in 2 years. So it's not always the case that dementia will result. This can also be a reversible condition if a patient is like on certain medications or recovering from an acute illness. So the most important take home, though, is if there is a diagnosis of MCI, we need to have more of that routine monitoring for cognitive loss. So this is a snapshot from the guidelines about the prognosis or course of disease for Alzheimer's patients. I would imagine that most of us are dealing with patients more at the right end of the spectrum in long-term care, and that's how I tried to gear the rest of the slides. So moving into some interventions, pharmacologic and non-pharmacologic. So before we dive into the medications, I wanted to review some of these non-pharmacologic strategies for caring with dementia patients, just some good reminders for us all to be aware of. Consider any vision, hearing, or other sensory impairments when communicating with these patients, and consider their optimal level of autonomy and adjust expectations for their performance over time. Avoid confrontation by remaining calm, firm, supportive if the patient becomes upset, and validate their feelings. Maintain a consistent, structured environment with a stimulation level appropriate for the individual. Provide frequent reminders, explanations, and orientation cues, and when explaining things, employ guiding, demonstration, and reinforcement. Reduce choices, keeping requests and demands of the patient simple and avoiding complex tasks that may lead to frustration. And bring any sudden declines in function to professional attention and redirect to an enjoyable activity. So the goals of our treatment will be to preserve patient function. So approved pharmacologic therapies have generally failed to demonstrate a reduced risk of progression. So our goal is to preserve function as long as possible and treat any neuropsychiatric behaviors that may manifest. So starting off with our cholinesterase inhibitors, they have a majority of their data in Alzheimer's disease. Patients with Alzheimer's disease have reduced cerebral content of choline acetyltransferase. So this leads to a decrease in acetylcholine synthesis and impaired cortical cholinergic function. So these medications increase cholinergic transmission by inhibiting cholinesterase at the synaptic cleft and provide a modest symptomatic benefit in patients with Alzheimer's disease. There is no convincing evidence, though, that they are neuroprotective or have the ability to alter the underlying disease trajectory. So their side effects do have to do with increased cholinergic activity. So this results in vasotonic effects in the cardiovascular system, and the same is happening with the GI system. So the increased cholinergic activity will increase smooth muscle contraction, peristalsis, and sphincter relaxation in the GI tract. So on this table, I tried to summarize very briefly the data we have on each of the dementia type for our cholinesterase inhibitors. So Alzheimer's disease, like I said, has the best data for a small to moderate improvement in cognition. So there is no great data about which is the best agent, though. So really, if a patient doesn't respond to one or has adverse effects with one, another agent can be tried. There was an interesting analysis that found the number needed to treat and the number needed to harm were the same for these medications in Alzheimer's disease, and that was 1 in 12. So if you treat 12 patients with these medications, one would benefit by achieving minimal improvement or better in their cognition, and one would develop a treatment-related adverse effect. So kind of an interesting statistic there about using these agents. For this reason, we'll be discussing how to discontinue these agents later on if you don't have an effect. And one study actually found up to 30 to 50% of patients have no observable benefit. So for vascular dementia, the benefit is about half of that seen with Alzheimer's disease, and this is uncertain clinical significance. So we do have some better data, though, for donepezil and galantamine in these patients. For Lewy body or Parkinson disease dementia, there is a benefit reported, not only in cognition, but also for psychotic symptoms, and we'll have a whole section on that later. We do have donepezil and rivastigmine having slightly better evidence. For frontotemporal dementia, it's not recommended because the cholinergic system appears relatively intact. The primary exception, though, would be if we are uncertain about whether the patient has frontotemporal or Alzheimer's, or maybe a combination. In such cases, you can do a trial of a cholinesterase inhibitor. So these are three options, a little more detail for you on dosage forms, starting doses, renal and hepatic dose adjustment. I really want to highlight donepezil seems to have the least GI side effects, but do recommend caution with the 23 milligram dose, especially for low body weight. It wasn't that much more effective, and we did see a marked difference in the GI side effects. Oral rivastigmine is typically not recommended, but we do have the patch, which is a great option, and be sure to recommend galantamine with meals. So next, we'll discuss our NMDA receptor antagonist, Namenda or memantine. Glutamate is the primary excitatory amino acid in the CNS and may contribute to the pathogenesis of Alzheimer's disease by overstimulating various glutamate receptors. So this leads to excitotoxicity and neuronal cell death. So memantine is an uncompetitive antagonist of the NMDA receptor, which is basically everywhere throughout the brain. So under normal physiologic conditions, the unstimulated NMDA receptor is blocked by a magnesium ion, and this magnesium ion will get displaced after the agonist depolarizes it. So in excessive receptor activation, which is what we think is happening in Alzheimer's, the magnesium ion is prevented from re-entering and blocking the channel. So basically this channel is constantly open, and it's just an excessive state of on. So memantine binds to this magnesium site, but with longer dwell time. So it functions as a blocker, but only under conditions of excessive stimulation. So if you're having normal neurotransmission, it's not really going to do anything. And for side effects, it's very well tolerated, but there are some of the most common side effects listed for you there. So again, a little summary slide of the data we have in each dementia type, but in general, we do have less data here than for our cholinesterase inhibitors. For Alzheimer's disease, our best evidence is coming from moderate to severe disease, but we do see this in practice used for mild as well. For vascular and Lewy body Parkinson's, we have some benefits on cognitive scales or global impression scales, but not on both. But kind of the take home for both is it's a well-tolerated medication and can certainly be tried. For frontotemporal, we actually have a study indicating increased risk for cognitive adverse effects with these patients, so would not recommend it in those patients. So here we just have a little bit more detail for you again on dosage forms, starting doses, renal and hepatic adjustment. Just wanted to highlight here that the capsules can be opened and sprinkled for ease of administration, which could be important for our patients who have trouble with pills, even for the extended release capsules. So how do we discontinue these medications, and why do we want to discontinue these medications? So withdrawal of cholinesterase inhibitors has been shown to reduce adverse effects, pill burden, medication management burden for caregivers, and cost. But discontinuing may pose a risk of cognitive and behavioral decline. So the patient really should be monitored closely. So if the medication needs to be reinstituted, it can. It's recommended to taper the dose by 50% every 4 weeks until the lowest available dose is reached, and then stop. You do want to monitor closely for withdrawal reactions. I listed the common ones there for each agent. This would generally occur 2 to 6 weeks after a dose reduction or complete cessation of therapy, but it is worth noting that the literature does state that a decline could be due to a disease progression rather than a medication withdrawal. The link here in the slide actually has a great algorithm for how to taper down and what to look for while tapering. So I'm always looking for great resources for tapering all meds, really, because I feel like that's a big part of what we do as pharmacists. So I think that's a great resource. So aducanumab is the first new therapy for Alzheimer's disease since 2003, which is very exciting, but there has been considerable controversy with this agent. So most of the controversy has come from the fact that the FDA Scientific Advisory Panel had previously recommended against approval, and the FDA actually did approve. So there were two reasons that they recommended against. The first was questionable benefit, and the second was significant side effects. So for the benefit, it has been studied on the surrogate endpoint of reducing beta amyloid plaques. So this surrogate endpoint has not yet been established as providing a clinical benefit. So we really don't know of the clinical benefit. And then, but so there are post-approval trials in the works to verify the clinical benefit. And then in terms of side effects, ARIA is our big side effect. So this is basically cerebral edema and hemosiderin deposition. So basically accumulation of iron in the brain that's leading to microhemorrhages. So in one Leqembi study, and Leqembi is our other option that's an every 2-week infusion, and our aducanumab is every 4 weeks. In one of the Leqembi studies, the number needed to harm was 15, so 1-5 for microhemorrhages. So these patients have to be very closely monitored with frequent MRIs. So this can be very difficult to implement in clinical practice. So the study protocol was an MRI within 1 year before starting, and then before the 5th and 7th infusions. And then for Aduhelm, they had an additional MRI required before the 9th and the 12th, and then for Leqembi before the 14th. So questionable benefit, a lot of side effects, a lot of monitoring, and very expensive. So we'll see how these fall into clinical practice, but it is exciting to have another treatment option, but we'll see how it's used. So some future directions, I thought some of these were very exciting, to be honest. There's some new vaccines in the works that are targeting the beta amyloid plaques and alpha synuclein plaques for the Lewy body and Parkinson's disease dementia that actually showed some promising results. So those are exciting, as well as deep brain stimulation showed some potential for Alzheimer's disease. And then hyperbaric oxygen therapy did actually improve the MMSE and the MoCA in patients after 1 month of follow-up. So some interesting things on the horizon out there. And I did want to touch on some of our herbal supplements we may see and we may get questions on. Basically, there's not a lot of great data. This is going to be a theme for me with you guys here today. But I think a vitamin E might be the exception. It did show a modest benefit similar to cholinesterase inhibitors, but it did have an increased risk for bleeding. So I think just taking your patient, into account with their specific risk of, adverse effects and other disease states that they may have. So ginkgo, showed no benefit, but it's very safe, unless your patient's on warfarin. So, just using all those things to tailor your recommendation for your patient. For vitamin B, really no great data unless you're vitamin B deficient. Omega-3 really just showed diets that have higher omega-3 intake are less likely to develop dementia over a lifetime, but no real evidence for taking the supplement. And then Prevagen, which is heavily marketed to certain patients, doesn't really have great or any evidence in Alzheimer's disease. So going through some non-pharmacologic approaches. So these all have evidence that they help improve quality of life, patients' feeling of calm and not feeling very stressed. So, these are evidence-backed therapies, and, very important to make sure that we have them somewhere, in our treatment plan for our patients. So aromatherapy, the administration of scented oils via diffusion, patches, skin cream, massage, any therapeutic touch applied to back, shoulders, neck, hands, or feet. And then multisensory stimulation. So this is basically a combination of light effects, calming sounds, smells, and tactile stimulation. And I did find an interesting study on bright light therapy. Exposure to stimulated or natural lighting, so sunlight, designed to help promote synchronization of our circadian rhythms. So this has been proven in just non-dementia patients to be beneficial. So I think this is a great one to be aware of as well. Music therapy and pet therapy, again, help all people. Meaningful activities is defined as the provision of activities designed to enhance quality of life through engagement, social interaction, and opportunities for self-expression and self-determination. But essentially calling back to what these individuals may have done in their careers and the majority of their lives. So if a woman was a stay-at-home mom caring for her kids, giving her a baby helps her feel calm, a baby doll, not a real baby. So those things do have great benefit in their literature for their effect. And then reminiscence therapy is referring to, positive memories via photographs or other prompts to help, reminisce on positive things. So I just wanted to take a moment to thank anyone who leads or create these activities for our residents and our patients. If we have any activities directors with us, I think this work is very important and can easily be overlooked in favor of some more quote unquote clinical interventions. But these activities have been shown to improve quality of life. So I just wanted to say thank you. So I do want to switch gears to talk about the management of neuropsychiatric symptoms. So this will be the case. So please keep this patient in mind. So this is an 86-year-old white female residing in memory care for severe Alzheimer's disease with an MMSE of 9. She's having severe agitation. I'm just going to take a sip of water. So her past medical history includes Alzheimer's, hypertension, diabetes, and anxiety/depression. So her current meds are listed for you there. And the provider wants to order an antipsychotic for agitation and asks you which one is preferred. So going into our management of neuropsychiatric symptoms. So these symptoms may include agitation, aggression, delusions, hallucinations, paranoia, wandering, depression, apathy, disinhibition, or sleep disturbances. So this can affect up to 90% of our patients. So a very common thing that we see. The first step is really evaluation for anything that we may have missed, any other underlying cause. Is there a medication that could be causing this? Is there any untreated pain, untreated depression, untreated sleep disorder that we can optimize first? And then assessing for delirium could be medication related, and it could also be related to an acute infection or other acute medical issue that's going on. So I did want to talk about some assessment tools that we have. So these measures have been used for reporting as well as research, but they don't really have an established role in clinical practice. So it's not really been proven that when we use these, we have better outcomes. But I think it's good to be aware of some of these because a lot of the way that these medications were studied did use some of these tools. So it is clear that each scale kind of measures things slightly differently. So I would recommend to pick one and stay with that one for that patient. And that'll really help you assess if you're getting a benefit from any medication you may use. So the American Psychological Association does have recommendations for management of neuropsychiatric symptoms in dementia. I think these are really great recommendations, so I summarize them for you here, but essentially they're guiding you through how to optimize steps before adding an antipsychotic medication. So we know antipsychotics have a lot of risks in these patients, and really, what can we do to minimize the need for them and then to make it as safe as possible when we do have to use them. So before starting any medications, we want to have a documented comprehensive treatment plan that is addressing the non-pharmacologic strategies we have tried, maybe if they haven't worked, documenting that as well. And then our plan for, what we think is causing the agitation and, kind of getting to the root of the problem. And they do only recommend medication for severe or dangerous symptoms that are causing significant distress to the patient. So if they are having a delusion, but their delusion is that, they're with their family and they're happy, we really wouldn't treat that with medication, for example. And then optimizing any non-pharmacologic interventions, all the ones I mentioned before, but also looking at any preceding events that might be linked with the agitation and determining if any unmet needs are, contributing to the agitation or if they can be anticipated or alleviated. So avoiding any environmental triggers, basically, or sudden changes in surroundings. It's also good for staff to review strategies involving distraction and redirection. So this can sometimes, help the agitation as well. And also just having a risk benefit discussion. So sometimes it's not appropriate to have that with the patient, but with any caregivers or family members to make sure that they're well informed of the risks and benefits of any medications that we may choose. So if we are going to choose a medication, we want to choose the lowest effective dose and titrate it to an adequate dose, and then give a 4-week trial. 4 weeks at an adequate dose is really what they recommend. If you don't have the effect that you wanted after 4 weeks, then we can try a different medication or just a different strategy. And then also keeping a close eye on any side effects that may happen. So we do know there are a lot of side effects of these medications, and then that would bring us right back to our risk benefit discussion. Depending on the side effect that the patient may have, did that sway the risk benefit for this specific example? And then if it did work after 4 weeks and we have, the agitation under control, we want to reassess again in 4 months and try to taper and withdraw the medication. Most patients do very well in the literature with a withdrawal of the medication, and the symptoms do not recur. However, if you have a patient who has a history of having recurrence upon withdrawal, then, you would just want to document that, and maybe they wouldn't be appropriate for withdrawing every 4 months, and you can extend that interval. And then if we are able to withdraw the medication successfully, we do want to follow them up closely for 4 months. 4 months is also their timeline for looking at if you are having any rebound of symptoms. So we do have some pharmacologic options, though, to consider before we get to our antipsychotics. So firstly, opportunities for deprescribing. So any benzodiazepines or antihistamines may contribute to neuropsychiatric effects in these patients. So we want to be sure if there's any opportunity to get rid of those medications that we try that. And then the evidence for the anti-dementia drugs on treatment of the neurobehavioral symptoms is not robust, but they are considered well tolerated and they can be considered. So we did see small benefits. We don't know the clinical significance of these benefits. And these patients did include, these studies included patients with relatively mild symptoms. So for our more severe patients, they may not be the best place to start with, but it's something that can be considered if those medications are not on board already. So we do have some evidence for memantine that they had diminished agitation and aggression. However, we do have a systematic review that concluded no clinically significant effect. For antidepressants, we do have 2 studies for citalopram that showed a dose of 10 to 20 milligrams was associated with reduced agitation and caregiver distress. And then trazodone actually found to have no benefit on neuropsychiatric symptoms, but if you have a patient that's having like a concurrent sleep issue, it's commonly one that we use. So we'll go on to the psychotic medications next, but I did want to mention there is no head-to-head comparisons between these medications and the antipsychotics for these symptoms. So it's very difficult to designate, which antipsychotic is the most appropriate, but we do know any antipsychotic for this indication will have an increased risk of mortality. So in 2005, the FDA issued the black box warning for the 2nd generation antipsychotics for an increased risk of death. So the cause for this is thought to be 2 reasons. Could be one, could be the other, could be both. We know 2nd generation antipsychotics increase your risk of a cardiovascular event by increasing, blood pressure, blood sugar, just metabolic syndrome. And then reverse causality is actually vascular disease that disrupts the frontal lobe and predisposes you to both behavioral problems and the cardiovascular events. So I thought that was kind of an interesting way of looking at it the opposite way. But then in 2008, the FDA did expand the warning to 1st generation antipsychotics as well. And it is generally regarded that the risk of mortality is higher in the 1st generation than the 2nd generation. And most of our evidence does come from haloperidol. So this is why Haldol is not recommended as a 1st-line agent. It can be considered in emergent situations because we do have an intramuscular short-acting, a version of it that may be good, in emergent situations, but in non-emergent situations, it is not recommended to be first line. So our side effects are listed for you there. So these are class effects that we want to think about with all of our antipsychotics. And then on the next slide, I'll go through a little bit of notes of, which ones are more known or less known for which thing. So this isn't meant to be a comprehensive table, definitely not. I was really just trying to summarize some of what the literature has found. So in regard to psychosis, risperidone seemed to be the best option. For agitation, there were 3 options that kind of came out as equally effective: aripiprazole, olanzapine, and risperidone. Olanzapine also had a benefit in the setting of Alzheimer's or vascular dementia. Ziprasidone really didn't have any information to say at all, in which situation it would be good for. And then the quetiapine data was not very compelling. I thought that was interesting because, at least anecdotally for me, I do see it a lot used. So I thought it was interesting that it didn't really have as great of data. But for Lewy body dementia and Parkinson's disease dementia, it's theorized that quetiapine and clozapine will have the least risk for increasing EPS. So in these patients, the risks of EPS with antipsychotics, are significantly greater than for, other types of dementia. So that's definitely something we want to consider. And in those patients, we do have pimavanserin or Nuplazid, so we can consider that as well for those patients. So overall, you just kind of want to take the specifics of your patient and try to choose an agent that will minimize the risks. So for example, if you have a patient with multiple other meds that prolong the QTC, maybe you wouldn't choose ziprasidone. If you're particularly concerned with EPS, you may not choose risperidone. And if a patient has issues with uncontrolled blood pressure or blood sugar, olanzapine might not be the best option. So really, from the data, there's no always start with this one kind of recommendation. So that's why, as pharmacists, we can really help provide the safest option in this situation. I also wanted to discuss Nuedexta as well. So this is approved for the symptomatic treatment of pseudobulbar affect, but it's also used off-label for agitation. So this is a high-cost medication, which is interesting because dextromethorphan is available everywhere over the counter, but the quinidine dose is different. It's much smaller than what you can get over the counter. So cost is an issue here. But it did find a statistically significant difference in 1.5 points on the NPI agitation aggression scale, but still we're not quite sure of the clinical significance. So you may see this one tried, but the adverse effects we want to keep an eye on are increased risk for falls, UTI, and diarrhea. So we do have a couple of other medications that have been studied, a couple anti-seizure medications. But again, as is the theme, data is not compelling. So carbamazepine did show a benefit at a moderate dose, 300 milligrams a day, but then we have a systematic review showing that it really didn't have enough evidence of clinical benefit. Valproate is often commonly used for as a mood stabilizer, but again, we have a systematic review that said it was not effective. Gabapentin also doesn't have great data, but if you have a patient who's having issues with pain, neuropathic pain or postherpetic pain, this could be a good agent to look at because we do see it as a collateral benefit of reduced agitation. Lamotrigine doesn't also have great data. And then melatonin, the data is very conflicting. We have one study that shows a good effect, one study that doesn't show any effect. If you know me, I'm a very pro melatonin girl. I think it's very safe and I think it's always worth a shot. If anyone knows of any melatonin data that shows harm, please send it to me. I'm always happy to learn. But yeah, I'm very pro melatonin. So for monitoring, this is the recommended monitoring per the American Psychological Association, the abnormal involuntary movement scale, blood pressure, fasting glucose, or the A1C, a lipid profile, and then weight with calculation of BMI every 3 months. So we'll go back to our patient case. So we can review them again, but essentially the provider is asking you which antipsychotic you'd like to order. So looking at their medications, they're already on Nemzaric, hydroxyzine TID for anxiety, losartan, and Lantus. So we can open up our polling question to see which would you guys like to do as the next best option for this patient. Okay, so it seems like we have a couple of different answers. So I am sorry that I gave you guys a trick question, but I thought it would be better for us to all talk through the options together. So the most common answer was reviewing non-pharmacologic interventions. I love it. Totally agree. That's always a good thing to do. I did think that I would consider discontinuing hydroxyzine the number one because we do have a medication that could potentially be causing the symptoms in this patient. But always reviewing non-pharmacologic interventions should be done concurrently with anything else we're doing. So I definitely think discontinuing hydroxyzine could be a good option for her. I also love everyone who said adding citalopram. She doesn't have any contraindications that we saw of adding citalopram, and she does have a history of anxiety, depression. So maybe the citalopram will help her, especially if we're taking the hydroxyzine away. So that could be a good way to kind of maybe avoid an antipsychotic. So maybe if we try those three options, then if she's still having the agitation, we can consider the quetiapine or the olanzapine. So I'd probably go with olanzapine as my last option because she does have, hypertension and diabetes. We don't know how well controlled this is. So it could be very well controlled, and olanzapine is a great option. But I would probably try quetiapine first, especially if she had some issues with maybe some sleep disorders that were keeping her up at night, maybe contributing to her daytime agitation. So I wanted to summarize with the 2018 Dementia Care Practice Recommendations that emphasize person-centered care. So I think it's really easy for us to get caught up in, our increasing workloads and sometimes decreasing staffing, but doing our best to put our patients first will always have the best results. So it's imperative for our staff to participate in education, develop new skills, and apply them to our patients. And I think, if staff and caregivers are able to view and respond to agitation and aggression in a way that is less emotionally charged and more from a place of empathy, it may help offset compassion fatigue and burnout, which are all too common consequences of working with individuals with dementia. So I would recommend, if your facility where you haven't yet looking into courses for building resilience. So this is kind of our buzzword after COVID, but patient or caregivers and staff who regularly deal with dementia patients, are even with or without COVID, can always use a refresher on building resilience in these times. So I also wanted to share some interesting training and certifications I found from Alzheimer's Association. And I also know of some facilities where you can send a consult to a behavioral health care manager. So this can help with some of those non-pharmacologic approaches that we discussed. And it's a great option to increase a multidisciplinary approach to care. And the World Health Organization also has great resources on this platform. I kind of fell down a rabbit hole researching all these things that they have available there, and it's all free. So really a great resource from them as well. And just also part of my random little summary potpourri, I wanted to make sure we all know about the plate study. This is not a new study, but it did find that dementia patients actually ate 25% more food from red plates than from white plates. So just in case anyone didn't know about this already, it could be low-hanging fruit for our patients who, have difficulty with adequate calorie intake. And it's really the contrast of the plate with the food. So if you were going to serve red sauce on a red plate, that's not really high contrast, but really just emphasizing if they can see the food, they're more likely to eat it. And then also randomly, I've had a lot of people ask me about this show as I've been putting these slides together. So I've not been able to see it, but blue zones have been an established thing where patients live for a long period of time with very low incidence of all diseases and dementia specifically. So I thought this would be, a great show, just for my own information, but just wanted to mention it in case no one else knows about it. But in summary, this is everything we talked about today, and I really appreciate your time. Thank you.
Well, thank you, Rachel. That was very informative. You covered a lot. I know that dementia is very complex and a lot of different things. I'll ask the audience if there are any questions. Feel free to put them in the chat and we can go through anything that you may have questions about. Interestingly, I just watched episode 1 of Blue Zones last night.
Oh, you did?
Yeah, so very interesting.